welcome everybody to the second day of the summer school, the Observatory Summer School 2020, to our digital event. I'm Dimitra Panteli. I'll be your moderator today. And perhaps I won't start by introducing our main speaker, but I will start by just welcoming you all and thank you for sticking with us. And with a couple of housekeeping issues for the duration of the lecture before I introduce our speaker, and then he moves on with the main content. As you will have seen, for those of you who were here yesterday, we have two options of participation for you. And I see already in the chat we have people from different places, so that's great. And please make use of the communication avenues that we have. One is the chat function, and one is the question and answer function. Both you can find when you hover your mouse at the bottom part of the screen of the Zoom presentation. And that's sadly only for those who are registered on Zoom and not for our YouTube colleagues. The difference between the two, we really want you to stick to this if possible. Use the Q&A with a little bubble to ask questions that you want the speaker to answer, and use the chat function as you are already using it for more general issues, for any comments that you may have or input, or any other general questions for me or for other observatory colleagues, not questions on the lecture. Please keep those for the Q&A function. The reason for that is the following. We will have Reinhard's lecture now in the beginning, and we won't interrupt him for questions. At the end, you will have already asked, you can type in your questions during the presentation though. And at the end, we will look at all the questions that you have asked. In the Q&A function, you also have the option to vote for questions that you find particularly interesting yourselves. So use that so that we can prioritize out of all the questions that you ask and make sure that we definitely tackle the ones that most people find the most interesting. We have about an hour at the end, a bit less, for Q&A. So we'll make sure to make use of the time as best as possible. But please try to help us by prioritizing in the Q&A. Having said that, of course, as the lecture or the presentation progresses, it's likely that you will have a specific question, which is why the slides all have numbers. So if you want to ask a specific question on a specific slide rather than a general question, you can always say slide 22, this is my question. I will be looking all the time at the Q&A and at the chat. So this is also the direct way to contact me, but I will not be interrupting Reinhard during his talk. And I think from the admin side, that's what you need to know for now. So Q&A only for questions specific to the content that Reinhard will be talking about. Chat box for any other question, comment you might have. And Annalisa already has put in the hashtag that we are using. So this is another reminder for me to remind you all to use social media to disseminate what we are talking about today. Use the hashtag OBS20 Summer School, Hospital, Innovation, and anything else that you use when you use social media. And I think without further ado, we move on and forward with the presentation. And of course, you all met Reinhard yesterday already. He's the director of the school, so he was there. For those of you who were here yesterday, he's not only the director of the summer school, he's also a co-director of the observatory as a whole. He's also the head of the research hub of the observatory here in Berlin. And of course, the head of the Department of Healthcare Management here at the Technische Universität Berlin. Reinhard, today the topic is anticipating and incentivizing change when planning and paying for hospitals. And this is also more or less the way the presentation is structured. Over to you. Thank you very much.
Yes, thank you, Dimitra. Welcome everybody. This is the second day of the summer school, and today we talk about anticipating and incentivizing change when planning and paying hospitals. And the program, what I have in mind today is that we have a more detailed look at hospital numbers in EU countries. Those of you who participated yesterday already saw some of them, but I want to go more into detail, especially in the topic of variation, because often when we talk about change, anticipating change, people have currently the COVID situation in mind, that we need to change something and that we need grand new ideas. But I will show you that often the ideas can come from other countries, that the hospitals sectors look so differently that copying ideas from another of neighboring country might already be very, very radical. And I also will present numbers because all of us basically know that the health system, the hospital sector look different in different countries, but most people have the feeling my own system is around average, and there will be some in this direction, some in the other direction, but it often helps to recognize whether you are at one extreme yourself. Then in the second bit, we want to look briefly at planning hospital care, especially on forecasting inpatient numbers and conditions. And then a big block on paying hospitals. And this one is based on a big project called EuroDRG, which I led a few years ago, and where we looked at the payment mechanism, especially of diagnosis-related groups across European countries. Let's start. We have, and I'm looking really on the acute care hospital sector, so we do exclude rehabilitation hospitals, which often are included in international databases. And so please don't ask me at the end specifically where I got the exact numbers, because the exact numbers are often not available for each country. I did some triangulation here to present an idea about the size. So we have in the total hospital sector in Europe, this is the EU 27 countries, by the way, we have 1.8 million acute care beds. Which is 400 per 100,000 population, but we have wide variation, which I will show you on the next slide. But already saying if all countries would be like Sweden, then we would have only half as many hospital beds. And if all countries would be like Germany, we would have 1.5 times as many hospital beds as we have in reality. So these are the EU countries plus a few other ones which I have also added. And remember, we have an average of 400, but we have countries, and Sweden is on the one extreme with 204, so 50% of the capacities of the EU countries on average. We have slightly more in Spain and Denmark. This is 2017 here. And then on the other side, we have Bulgaria with 617, Germany with 602, and Austria with 545. And we have all other countries somewhere in between here. You see the countries marked with white numbers. On the dark countries are those countries in the center and towards the east, which are above average, while the countries with the black numbers on the lighter colored countries are those with fewer beds than the average, and they are in the north, in the west, and in the south. And we have a difference of factor 3 between Sweden and Germany, or I could have also said between Sweden and Bulgaria. So hospital is not hospital in one country as it is in another one, and we need to recognize that. I want to present on the next one, we look at the intensive care unit beds, which were of particular attention this year. I think previously nobody really cared so much about the intensive care unit beds. And what I did here is I present two numbers. On the one hand, I have again the numbers per 100,000. and on the other side, I have a percentage. And we have this slightly, you could say, paradox situation that the countries here marked again in white, which have more beds in general, not only have more ICU beds, but also relatively more. So Germany, you see, they have 6% of the huge number of beds, which leads to 32, while Sweden again on the other side has fewer percentage, only 2% of all hospital beds, which amounts to 5. And so this is important when we address, and we will do that next Monday, when we look at the health system response in the current crisis. And you all know that the intensive care unit beds were one factor, but also see here on the right-hand side that the difference is much larger, factor 7 between countries. Every bed which we have, again with certain variation in the EU countries, is used for about 40 inpatients per year. So we are talking in all EU countries together where we see about 75 million inpatient cases, meaning that more than the population of France is hospitalized during a day. This leads on over the course of 1 year to 500 million inpatient bed days. When you think of an average European citizen, meaning that an average citizen spends about 1.1 days per person in hospital. But again, that varies. We have countries like Sweden, Denmark, where this number is only 0.7, and we have countries such as Bulgaria or Germany, where the number is more than twice as high. And the number the number of inpatient bed days is due both to the number of hospitalizations, how many people are hospitalized, but also due to the length of stay. And looking at overall length of stay is not that telling, because a mixture of patients is also different from one country to another, and I will show some examples of that. But when we look at similar patients, and this is the example of acute myocardial infarction patients across EU countries here, we see that the average length of stay is only 3.7 days in Denmark or 4.3 days in Sweden, while it is 10 days in Germany and 9 days in Estonia. So we have a variation for the same type of patients here of 2.7. Clearly, there will be differences also when people move from acute care to rehabilitation, partly explaining this. But it also means that again, that countries have very different ideas when you talk about that is a hospital. We have, when we look at an average day in European hospital care, we have 200,000 people in the EU 27 countries are admitted at inpatient at any given day, and with an overall length of stay across all countries, across all conditions, of about 1 week. That means that we have 1.4 million beds out of the 1.8 million beds which we have are occupied each day, which means that more than the population of Estonia are in hospital each day. Or remember, or think of the EU, and the whole of Estonia is a big hospital, and all the people in Estonia are hospitalized. I mean, just to get an idea of how huge the sector is. But many of these people do not have to be in hospitals, and this is what I just said already. We have, every country thinks you do certain things, and these are and doing it like other countries would already be a radical change. This one looks at people who could be treated on a day case treatment, meaning they don't stay overnight. They come in the morning, get their surgery, and leave in the evening. And this is the case here of tonsillectomy performed as day cases. And you see on the left-hand side, we have Finland, where basically it's normal that people get tonsillectomy as a day case. The latest figures there from 2016 are 87%, but also please see that the gray dot in the year 2000 in Finland was less than 20%. So the big change there, nowadays it's normal, it's a day case, while when we look on the right-hand side here within the EU countries, Slovenia, Hungary, Austria, nobody is treated as a day case. So when you talk, or when you're based there yourself, when you talk to the colleagues in these countries, they will say, no, it's typically an inpatient case. And we have data here from 24 countries, as you see. So the average is 30%, which really means wide variation. Another topic which should lead us to question the high number of inpatients in Europe are the so-called ambulatory care sensitive, also called avoidable hospitalizations. The idea here is, and these are the classic 5 also categorized by OECD, are diabetes, hypertension, heart failure, COPD, and asthma. And the idea is that these people are optimally treated in ambulatory care, and when they are treated as inpatients with the main diagnosis of this, obviously there will be diabetics in hospital treated for other things, but these are the ones who are treated for their main diagnosis, that either the ambulatory care sector does not have enough capacity, and that's why people go to the hospital sector, or something went wrong in the ambulatory care sector, and for example, diabetics need an amputation, which they then get as an inpatient. And look please at the number here of admissions. In total, we talk about 5 million admissions and almost 38 million bed days. This is more than the entire hospital sectors of the Netherlands and Belgium combined have. So a big part of our inpatient capacity is used on cases where it's questionable whether we should treat them, and in hospitals. And again, we see big variation across countries. These are the EU countries again on the left-hand side, and some other selected countries on the right-hand side. We have 2 pieces of information here. We have the blue bars, which gives us the percentage of the number of patients in hospital, and this varies between 8.6% in Bulgaria. So in Bulgaria, 1 in 12 patients is admitted for causes which are debatable, and 3.9% in Slovenia and 3.7% in Croatia, meaning it's only 1 in 26 patients there. And you have the white dot there, which gives a rate per 100,000 population. Highest value again in Bulgaria, second highest in Romania, third highest in Germany. And I also put in the differences among countries. We see factor 2 regarding the percentage, and even factor 6 regarding the population-based figures. Why this difference between the 2 arrows is that typically in countries with more hospital beds, we also see more patients admitted for avoidable conditions. And Bulgaria and Germany are our typical examples for that. Clearly, the hospital sector, and today we are also talking about money, has huge monetary implications. We are spending in the EU 1.3 billion euro each day, which when we now heard from the summit in Brussels and the big sums, 750 billion, I mean, you know, we spent 700 billion in 2 years, or actually more than 700 billion in 2 years on our hospitals. So in that sense, you know, it's then relative. 1.3 billion each day, which is more than 1,000 euro per EU citizen each year. And it's 37% of total health expenditure, or 3.7% of our gross domestic product. Those who were here yesterday remember that I compare it to total government spending on education. And this is education from kindergarten, primary school, secondary school, right up to universities. So we only spend a little more on education than we do on hospitals. But it's also a major source of employment. We have, and this is in full-time equivalents, the number of persons is even higher. So we have 1.8 million nurses working in hospitals and about 0.8 million physicians. We will be talking about the skill mix on Thursday separate, and both on skill mix and what we can move from one profession to the other one, where we can use machines instead of personnels. But for today, I want to put this in relationship again to the to the various countries, and this one puts the this one looks at the number of cases. So the data are per 1,000 hospital cases in a year. And let's start with the orange line here. These are data from 2006. You see, for this is the orange line is for the Netherlands. So you see 10, which means that for each 1,000 inpatients in the Netherlands, you have 10 full-time equivalent doctors, or the opposite, or you could say per 100 patients treated in the hospital sector in 1 year, you have 1 doctor, and then you see it's 30 nurses per 1,000 patients. I also marked here Germany. In Germany, it's both fewer physicians per case and fewer nurses. And I marked Denmark on the other side, which was a country where we had data with the highest ratio of nurses and physicians. And these are 2006 data. Here is 2015. And you see, while in Germany not much has changed, so it's still the same number roughly of physicians and nurses per 1,000 patients, that both the Netherlands and Denmark, which I have selected as examples here, have now more personnel per patient. And if you compare Denmark with Germany, which are 2 neighboring countries, there are 2.4 times as many physicians per 1,000 patients as in Germany, and even 2.7 times as many nurses than in Germany. Many people then misinterpret these data and think that in Denmark there are many more nurses than in Germany, for example, which is untrue. When you look at population-based figures, you see that Denmark and Germany roughly have the same number of professionally active nurses. What is the difference is that remember the bed days and the cases, that in Germany there are many more people hospitalized than in Denmark. So in Denmark, fewer people are hospitalized, but there is the same number of staff available. So per patient, there's much more staff. This was the first bit, just to get a few numbers. Now we move on to planning and paying. And for this purpose, it's necessary to briefly introduce a triangle in which we think health systems. As health system researchers, we move basically one level up and say, okay, who are the most important actors within a health system? And we have the population and we have the providers. And the providers in our case here are especially the hospitals. Clearly, in the broader sense, we also have GPs, pharmacies, and so on. Then the population pays to the collector of resources, and the population pays in tax finance system. They pay tax money. In insurance-based systems, they pay sickness fund contributions. And then the collector of resources, which in the tax finance system would be the Ministry of Finance, passes the money on to the payer of health services, or in insurance-based systems, and the payers are the sickness funds. And we have the regulator, which is typically the government, either the parliament and or the ministry, which regulates. And important when we say we want to plan and pay providers is that we assume a relationship between the payer and the providers. And we call the process, we call that purchasing. So purchasing means in this respect that that somebody, the payers, need to make a decision on what services they purchase, they buy from the providers. And the purchasers, the payers, should have an idea what kinds of services do they need and from whom do they need it. And we have already seen examples with the ambulatory care sensitive conditions. So clearly you could purchase the diabetes care from hospitals, but you could also say as a purchaser, I want the diabetes care from ambulatory care providers. And last but not least, and we'll be talking about when we talk about the money, how to buy and pay, because we assume a relationship here that the purchaser not only plans how much is needed for the population, not only from whom it is needed, but also that the way the purchasing functions, that there are clear signals, incentives for the providers to do as good a job as possible. And when you go a step further, and this is from the World Health Report 20 years ago, strategic purchasing are proactive decisions about which services should be purchased, how, and from whom. And we have two extremes here, basically. We have, if purchasers are not active purchasers but passive purchasers, then we have a resource allocation typically based on geographical and even more often institutional figures or historic figures, meaning that you have a Ministry of Health which gives money to a hospital, and the hospital pays the staff, and it's independent really of what the actual activities or needs are. Clearly it has an advantage that the providers, in our case the hospitals, know the budget in advance and can plan accordingly. The disadvantage is that it is not really based on actual workloads, outcomes, or new technologies. So the money is simply given to hospitals for being there. In the current crisis, many people think that this would be good, give enough money to the hospitals and then they will take care of the hospitals. But we need to ask ourselves whether this is really the best way to allocate our money. The opposite is strategic purchasing, and the strategic purchasing requires active purchasers which follow the epidemiological numbers and say, okay, how is the epidemiological situation in the area for which I purchase services? And then they sign contracts with the providers. and which defines actually which interventions, and the interventions should be selected based on cost effectiveness and needs criteria, how this is done. So how are the incentives, the monetary and other incentives related to what the hospitals are doing, and from whom, under which conditions, and what is required, especially regarding quality. The advantage of such a system is that the services are obviously ideally financed according to population health needs and cost effectiveness. So this is a more rational system. Obviously, there are disadvantages that it requires information which is often not available or comparable, but which does not mean that we should sit back and say we simply give the hospitals an amount X and they know what to do. And this also relates to what we talked about yesterday when Martin McKee at the end said, you know, we need more clinicians who are also getting involved into health policies. I mean, clinicians usually assume that they know what to do. First of all, we see these big differences between countries, so it's often important to also for them to compare across countries, but it's also the environment in which they work, which is to a large extent determined whether we have the active or the passive purchasing. The second, or then related, when we say, okay, we need active purchasing, strategic purchasing, and that should be related to the population needs. And too often, also among policymakers, I always hear that the burden of disease is going up. We have more chronic people and everything is becoming worse. I hope that you are aware of the Global Burden of Disease study, and if not, please check their web pages. This is based on the Global Burden of Disease studies, and it looks on the actual burden of disease, constituting in part clearly the need for the healthcare sector or the hospital sector in particular to provide services. And this one measures the global burden of disease here and so-called disability adjusted life years, which is a combination of both years of life lost, so people who die prematurely of certain conditions, and of people who are still alive but who are disabled, have a lower quality of life due to these conditions. And when we check this across the world, we see that the global burden of disease per population, so this one looks at per 100,000 people, has decreased in the period since 1999 by minus 30%, because it has gone down quite drastically in low and middle income countries. When we look at the EU, it also has come down by 10% over this period. Maybe in the last years, you see that the curve has flattened. Maybe there's even a small increase. So possibly it's true, or it will become true, what we have thought all along, that the burden of disease, the treatment needs are going up. But this is very, very slowly. Within the EU, we see great variation. We have Cyprus also at minus 10%, which is considerably healthier, the Cypriots, than the rest of the population. We have Norway as a non-EU country, where the decrease was surprisingly high at minus 20%. But we also see a country such as Bulgaria, where the burden of disease has actually increased. And when you compare the burden of disease now between Cyprus and Bulgaria, there used to be a 50% difference in the year 1990, and now there is an 80% difference in the year 2017. So in a sense, you could say maybe it's appropriate that Bulgaria has slightly more hospital beds than other countries, but clearly the difference, as we have seen, is considerable, and they have avoidable hospitalization. So also they have to revisit their hospital structure. This one is the overall burden of disease, and we can also break this down. So then we see, okay, what diseases constitute the burden of disease. And I think we all know somehow that the panorama of diseases, the disease spectrum is changing, but I think we are less aware that it is really changing a lot. This is again the same period here from 1990 to 2017, so a 25-year period, one generation. In 1990, ischemic heart diseases were responsible for 13.5%, together with stroke for 20% of the disease burden. When we now look and remember, the overall disease burden has gone down, and the percentage within the smaller disease burden for ischemic heart disease and stroke is now only about 13%. Maybe you don't recognize here that there are other diseases which have increased here. So I put this pancreas carcinoma, which was 0.8% in 1990, which is now 1.2%. So it's important, and we have data to monitor actually which disease burden is going up, which disease burden is going down, and to readjust our hospital sector appropriately. And this one leads then to the question, how do we implant the changes which we need? So we anticipate we have changing need for hospital treatment. And how do we transfer this in the strategic, the active, proactive purchasing onto the providers? Because often, and I would be interested to hear otherwise, often the policymakers, the health insurers, they have limited power to actually then determine inside a hospital, let's say, you know, who is treated there. So we rely on contracts and on money that the hospitals are treating the patients which should be treated, and that the changing disease panorama, the new intervention technologies, which often mean that we can do things on an ambulatory care basis, a day case basis, that this also reaches the hospitals. And I usually ask because this one is, you can ask policymakers. And it's interesting that you get so little response actually. When you ask a simple question, if somebody, can be the sickness funds, can be the Ministry of Health, is paying hospitals, you should ask yourself, what are we actually paying the hospitals for? And most people say, yeah, we pay them to do things. But clearly we have more ideas as policymakers, as purchasers of health services. And the first question is, or the first thing which we want to make sure is that they, meaning the hospitals, take care of patients when they need care. This is probably foremost our worry, and that they do not risk select. So that the need of the patient determines who is treated, and not the patients who are most attractive to the hospitals, that they do provide services at all, and that they are not idle, keeping wards empty and so on. But we not only want that hospitals are active, are treating patients, we actually want that they only provide services when they are appropriate, and not because a hospital has empty beds and would be paid for additional patients, that they treat patients who don't need treatment. That leads to the next thing is, we would like that expenditure is well controlled. Sometimes this is forgotten in the current crisis. Some health ministers pretend they have all the money in the world, but I showed you that even in the past we have already almost spend as much money on hospitals as we have on education. And clearly money is not unlimited, and we need to see that it is controlled. And part of this is that services are efficiently provided. So it's not only necessary that hospitals treat patients, but that they treat them efficiently, meaning they don't waste resources. And when I say they don't waste resources, it's not only, and maybe not even primarily, about the money. It's also about human resources. It's about technological capacities. So if we have a limited number of ventilation beds, we need to make sure that we don't ventilate patients for longer than necessary if there is a queue for the ventilation units. We also want that service provision is transparent. So we would like to know what hospitals are doing. And in many countries, this is a black box, which we also notice in the current situation. Suddenly, all the ministries, but also on the EU level, on the WHO level, at the OECD level, we were interested how many patients, for example, with COVID are treated, how many of them are ventilated. And suddenly, we realized in many countries that we don't have the capacity or the institutions in place which actually measure what is happening. And last but not least, we want that services are provided of high quality, and that patient safety is not endangered. We have certain ways to pay hospitals, and there are three main ways. We have fee for service, which means that every single service is paid separately. So the hospital would get money for every ECG, each physical examination. I jump over the per diems. Then we have diagnosis-related group payments, where a provider, typically an acute care hospital, receives a sum of money for a patient depending on the condition by diagnosis, but also the procedure, including all services from admission to discharge, including surgery, pharmaceuticals, and so on. And we have a global budget where a certain fixed amount of money is given to the hospital to cover the treatment costs of all patients coming to the hospital during that year. We now need to think, and I said we have a list of questions in mind, and these are again in short form here. We want that patient needs are taken care of. We want activity. We want expenditure control. We want technical efficiency. We want transparency. We want quality. And last but not least, it should also not overburden our administrative system, meaning it should be administratively simple. If we pay hospital fee for service, it's and the plus sign means here it's good. They do not select patients. Every patient is a good patient. They have lots of expenditure, but clearly this is negative for expenditure control. It's technically not very efficient. It's not really transparent. We get long lists of services provided, but we don't have transparency on actually important ones. There are no particular quality incentives because there's a risk of overtreatment. We pay hospital, and the more we pay them, the more they do. And it's also not administratively simple. On the other hand of the spectrum, we have global budgets, and global budgets to a large extent have the opposite incentives. So if we give a certain amount of money to a hospital, why should the hospital be particularly active in treating as many patients as they could? On the other hand, it's good for expenditure control. Again, it's plus, minus, or zero for technical efficiency. It's a definite minus for transparency. We have no idea what the hospital is doing, but it's administratively simple. And then in the 1980s, starting from the US, we had DRG-based case payments. Now, in lots of countries, we pay hospitals by these diagnosis-related groups. also not only pluses, but clearly a more positive incentive structure. They have an incentive to treat as many patients as possible, but they have a disincentive to provide as many services as possible per case. Expenditure control is a bit in the middle. Technical efficiency, because we give them a limited amount of money, has positive signals. Some people say it's forcing hospitals to be too much technically efficient. Again, quality is zero, and it's also administratively complicated. This is a more a remark. And the US, which started to introduce DRGs in the 1980s, they talk about a prospective payment system, because you do not calculate anymore retrospectively what the hospital has done, but you give them a prospective sum of money per patient. While most European countries, which introduced DRGs in the 1990s or 2000s, they often call it's an activity-based, because you now give money to the hospital for each patient treated. And it's actually, so DRGs are less prospective than the budget. The budget is the most prospective system you can think about. So it's whether it's prospective or activity based really also depends on where you come from. It's important that people, or many countries, they look in the US literature to anticipate the effects of a change to DRGs. But if you come from a budget system, and many countries are coming from the budget system, the changing incentives are totally different than the changing incentives in the US was. So it's important to have in mind this figure here with the changing incentives. There are, when you think about it, there are certain observations when we compare these three ways to pay hospitals. And the one is that all payment mechanisms provide conflicting incentives for activity and expenditure control. So if you incentivize hospitals to do as much as possible, you risk going bankrupt. And if you keep your expenditure well under control, you risk that the hospitals are not as active as you wish. With DRGs, probably the best compromise in the middle. None of the payment mechanisms provide incentives for producing high quality outcomes, which is really worrying. We have, on the fee-for-service side, we have the risk of overtreatment, and on the budget side, we have the risk of undertreatment, and we need to find ways to adjust payment for quality. And because, and there's a typo here, that should be choosing, and clearly there is a need to mix these payments, because they all are good in regard to certain incentive structures, but they are bad in regard to other ones. And so countries have experienced and are experiencing in supplementing their DRG payment system by quality incentives. And what you can do, and these are just examples here how you can think about it, you can adjust the payment for an individual patient upwards or downwards. For example, if the patient is discharged maybe too early and has to be readmitted after a few days, then you would go to the hospital and say, wait a minute, you discharged the patient too early, and as the patient is coming back, you're not getting a separate DRG payment. Or you say certain complications, and often complications lead in DRG systems to the paradox situation that is that the hospital gets more money, which Let's say you have a surgery, there's a complication, you need to do a second surgery, and the case with 2 surgeries is giving more money to the patient than a case with one surgery. This is a paradox incentive that hospitals are paid for bad quality, so there are ways you can adjust that and take out these complications which are most likely due to the hospital. You can also say, okay, I look at all patients with a certain diagnosis or all patients with a certain disease and look at the average results, and I adjust the DRG payment for these for these hospitals, for example, by defining certain quality standards and pay more or no money at all if they are not met. For example, if stroke patients are admitted, you would say, okay, I expect, so as a purchaser, you go to the hospital and say, I would expect that you treat the stroke patients on stroke units, because I know that the outcomes on stroke units are better than if patients are not treated on stroke units. And so the hospital would then, let's say, if they achieve that at least 90% of their stroke patients are treated on stroke units, they would receive more reimbursement per stroke patient. Or you say, I adjust the overall payment to the hospital based on certain results which I measure across all patients, independent of their indication, independent of their disease. For example, if the overall readmission rate is higher than average, or if I have predefined quality results, for example, waiting lists and so on, and if these are not met, then the payment is adjusted downwards, and maybe it's adjusted upwards if hospitals have better than average quality. Countries, as I said, experimenting with this, and the experiment means that we assume that hospitals react to financing. So if we pay them, that they change accordingly, which is a matter of debate, and some people rejected the notion and say no, the clinicians only act on behalf of the patient. On the other hand, we know when we look at the characteristics which define a DRG, which you could say is a bit simplified, coming from 3 sources, coming from the patient. So we look at the patient, age, gender, diagnoses, comorbidity, and so on. We look at the what I call the medical and management decision variables here. So whether a hospital is putting a patient with a stroke on the stroke unit or on the normal ward, or if they put a COVID patient on ventilation or not on ventilation. So this is their treatment decision. And the last bit is the characteristics of the hospital itself, number of staffing, wages, and so on. And when you think about that, we have a conflict. I mean, some people say hospitals are reacting, and if they do react, if they select patients, we say they're doing a bad thing. But you know, and then gaming means that hospitals are only doing it if we give them additional money, and hopeful, and we think they are not doing it because of the money. On the other hand, we see in certain countries that if we pay more with the stroke unit, for example, that they also put them on the stroke unit. I will show you some examples in the next slides. And so there's a trade-off that we expect that hospitals react to money and that they improve the quality. But on the other hand, we are worried that they react also on other incentives and maybe to the disadvantage of the patients. And often it's a fine line the reaction of hospitals to financing incentives is a fine line, and often it's, for example, we accuse them that they throw out patients early, and on the other side, it's often important to reduce the very long length of stay. So often people who are against DRGs as a payment mechanism would point to the negative effects, while the same behavior of the patient, of the hospitals, also produces positive effects. I only in the last few minutes want to point to a few examples where we have looked at whether this is really true. And in the already mentioned Euro DRG project, we looked at a range of countries, more than 10 countries in Europe, and examined whether financial incentives or paying for certain patients also means that patients are treated differently across countries. And let's look at this example here. This is an acute myocardial infarction patient, and we defined an index case, which is the most prevalent case. So we said it's a non-ST elevation myocardial infarction, no complications, no invasive treatment, length of stay 6 days. And then we had 6 other cases, and I only point to cases 3 to 6 there because they all get a PCI. So we do an angiography, put in a stent, partly a bare metal stent, patient 3, or a drug-eluting stent, patient 4, which are clearly more expensive. And then we looked how would hospitals be paid for treating these different patients. The index case is put at 1, and the other 6 cases are then we compared the average treatment. Let's look at France, for example. In France, patients 4 to 6 are paid much higher than patients 1, 2, and partly 3. While in Ireland, they are all paid more or less the same. And in England, also the different payment rates are by far not as pronounced as in France. And then you can say, obviously, we this is now leading to the question: where's the hen? Where's the egg? We see that in England, hospitals are not paid much more if they input a stent, while in France they are. And we see that in France, 57, these are already quite slightly old data, so that might have even changed more. Already at that stage, 57% of AMI patients were receiving a stent in France, but only 16% in England. So yes, we see a high degree of correlation in what we pay hospitals for and what they do. This is another example here on strokes, same idea. And we see that countries are incentivizing certain things. For example, in France, if the patient dies, there's a relatively high payment, which you would say has maybe paradox effects on the quality, while Poland pays thrombolysis if the patient stays for more than 7 days, especially well. Germany incentivizes the stay on stroke units. Austria, the thrombolysis. Sweden pays more if the patients have more secondary diagnoses. England and Estonia basically pay all stroke units, at least at that time, more or less the same. So there is, often we think, yes, there's a DRG system, it's meaning one price per patient, but the way how the incentives are embedded into the DRGs makes a big difference. There's one last example which I want to jump over here, and this is the final conclusion here regarding the payment. And it's important. We cannot pay everything with DRGs. And I think some countries have overdone it. And I use my own country as an example here, Germany. We used to pay everything with DRGs. And then we have the perverse situation that the emergency room or the costs for the emergency room then have to be covered by the patients who come into the emergency room and then are admitted. So clearly the emergency room doctors have a high incentive to admit as many patients as possible who come into the emergency room due to the wrong incentive structure. So we would say, no, we have to pay the emergency room separately, maybe a bit like we pay our fire brigade, not only if there is a fire, but we pay them for being there. But normal cases, the treatment, then we should have diagnosis-related groups, which are in clinically meaningful group, and they should probably be adjusted for quality, and we pay separate. And this is the idea, you know, remember my French case. If you want that AMI cases get a stent, you probably need to pay extra for the stent. If you want that stroke unit patients are treated on the stroke unit, you need to incentivize that if you don't include it into the quality. So there's a fine balance. In conclusion, I would say we need to know where we want to go, and most countries can learn from other countries. We have to look at the disease panorama, but then use contracts between the purchasers and the hospitals more wisely, and think very carefully about which incentives are sent by money and how we can use them for the benefit of the patients. These were my figures, my thoughts for today. Thank you for your attention. And back to our moderator.
Thank you very much, Reinhard. We have very active participants. So we have a number of questions in the Q&A. I think it could be even more active. So what I would like to do is I would like to ask everyone to look in the Q&A, look at the questions that are already there, and give your vote, your like you're on Facebook, to the questions that you think you also want to see answered. We will start with the top one now, but you also now have the chance to add new questions. And the first question is in part already answered because you mentioned it specifically, and it's about emergency departments. And what is the most suitable payment mechanisms for emergency departments? Because cases are often undifferentiated. It's not the same as differentiated ones. And so you already mentioned the fire brigade, but perhaps a little bit of an additional insight on that.
Well, I said it's important that not only do we have undifferentiated patients and patients who come in with symptoms often rather than diagnoses, and we want to take out the incentive for hospitals to admit patients only because they are paid for admitted patients. And that's why the emergency room should be paid in a budget-like fashion. And this also would contribute to fairness across hospitals, because otherwise a hospital in a very rural area with few patients would need to recover the costs across much fewer patients than an inner city hospital, which is over flooded by patients. So yes, take emergency rooms out of the DRG payment and pay separately in a budget-wise fashion, which means you adjust the payment by the size of the emergency room, the number of staff, the number of technical equipment available.
Okay. Thank you. I hope that's okay for Kayan, who asked the question and who asked this question before you brought up the example, I have to say. So it fit really well also in the flow of the presentation. The second and third questions ranked similarly are both about COVID. So I think you can start with answering, but I think we'll also come back to that next week. And it has to do with the fact that payment systems were really not fit for purpose or unadapted for COVID. And how do you think that the new situation will influence payment models, and how can we perhaps adapt DRGs or fee-for-service to reflect the new needs?
Well, I mean, it differs, by the way, a bit from country to country, because I mean, the term diagnosis-related groups for many people has the has a D, the diagnosis, in there, and clearly countries did not have a diagnosis-related group for COVID. Other countries put more emphasis, even within their DRG system, on treatments. And that, for example, ventilation is a good example, that they would have ventilation DRGs, which has nothing to do with a D, because it doesn't matter why patients are ventilated. The hospital is paid for ventilation cases, and at least these patients fitted very well into the DRG system if the ventilation is the most obvious one. Then other patients, if you have a general DRG, let's say on severe pulmonary disease, it could also fit. Clearly, what was not included, and depending on who was responsible in the various country, was additional costs for personal protective equipment and so on. So DRG payments are based on expenditure on costs in the past. And so clearly, if suddenly the costs are changing because new procedures like putting everybody in protective equipment are necessary, then this is not covered in the DRG, and then countries need to think of the extra costs and pay extra on top of the normal payment system. So, which again means that even if we have the seemingly perfect payment system, we always need to be aware that unexpected things can happen, and we need to supplement our system if it works well under normal conditions.
There is a follow-up question on this, so I'm going to go ahead and bring it through, and then we go to the next ones. And it has to do with other patients not coming to the hospital. And Caroline says other patients did not come to the hospital, so revenues from other DRGs or treatments wouldn't flow, so dried out. And how do we then pay providers during this drought in that sense?
Yes, I mean, first of all, and we come on Monday in the second week, we come to the COVID specific ones, and there's also a web page of the European Observatory, which you will introduce on Monday, and which has policy briefs on many of these issues. So clearly, the more our providers depend on payments per case, DRG based payments. I've already said the emergency room I would leave out, so it wouldn't really matter if there are fewer people in the emergency rooms now. But for the remaining patients, if you pay per patient and there are fewer patients coming, and there have in many countries, there are more patients not coming than there were COVID patients. So the overall utilization rate, maybe paradoxically and against what the media are transmitting as a picture, the hospitals are emptier. So then you and countries again varied in their approaches there, how they made up for that. For example, whether they paid for empty beds, and they say, okay, we know, first of all, we want that you treat fewer elective patients to have more spare capacity, and usually hospitals are not paid for spare capacity. Many countries all of a sudden changed their payment systems and now said, okay, we pay you for creating spare capacities in just in case there are more COVID patients coming. So I think we saw, I mean, that is the interesting thing, which we'll be looking into more detail next week, is that suddenly, I mean, things became possible, which until a few months ago, policymakers in the country would have said, no, we would never do that.
Okay, thank you. And as you rightly say, we come back to that specific COVID topic in more detail next week. We change a little bit the subject now and go to an earlier stage of the presentation about the ambulatory sensitive admissions. And there is a question that asks, that a high number of hospital admissions means that the primary healthcare system is not well developed, perhaps in in Eastern European countries, or is it a different philosophy of where the patient should be treated? Is it the different role of primary healthcare as it has developed over time?
Well, first of all, I mean, I think we don't go back to the slide in detail, but the interesting thing was that it was not, if you look at the percentages, that it was not a pure East-West phenomenon, because we had both countries with the highest percentage of ambulatory care sensitive conditions, Bulgaria, Romania, and also with Croatia and Slovenia among the lowest ones. So it's not East and West. It's so we need to look in a bit more detail what we can learn about the ambulatory care sector. But I personally, I've come to the conclusion that maybe the explanation that it is only a factor on ambulatory care is a bit too short. So I would say this is more the push factor. So there's a push factor from bad ambulatory care into the hospital, but there's also a pull factor. And we saw that the countries with a large hospital sector also have the highest percentage of these avoidable hospitalizations. And so there's clearly also a factor that the hospitals, by having so many beds, and if they are paid for treating patients, that they suck in patients through their emergency rooms. And I think we need, and probably after this crisis, we will put much more emphasis also on our emergency rooms, which were a bit forgotten in much of the health services research, that we always think that people are either referred to hospital from ambulatory care, or that there are real emergencies, acute myocardial infarction. But we didn't realize that there is a big gray zones. People go by themselves to the emergency room because their ambulatory care sector is closed maybe, and then the hospital makes a decision whether the patient is admitted or not. So this is a gray zone. And we would expect that depending on how the hospital is paid, how many spare capacities they have in this moment, that they will admit patients which they would not admit in other instances and in other countries. So it's as important to look at the hospital sector and disincentives to keep people out of hospital.
Thank you, Reinhard. We have now two questions that have to do with the burden of disease. And the one is more about whether you think that the disease panorama, as you mentioned, changed because of incidence and prevalence changes in population level, or also the change in technology, diagnostic technologies. And a linked question, because it was the topic, is whether the slide with the burden of disease over time meant to say that the increasing number or prevalence of NCDs will not necessitate an increase in hospital beds. So this is a double.
I start with the latter, and I think it's clear that when you think that many of the chronic diseases which are increasing, especially with increasing old age persons, are at the same time many of these ambulatory care sensitive conditions, that the link in many policymakers' minds, we have more chronic disease, we need more hospitals, is too short. And that rather we should think, okay, what do we do about chronic diseases outside hospitals? We need to think of better providing care, often thinking not of individual diseases, but of multimorbid patients clearly. And we forget that the ambulatory care sector is often open only for a certain period during the week. For example, if the general practices are open for 25 hours a week, it's only 15% of all the hours, and during the other 85%, people go to the hospital emergency rooms. So there is need to increase the capacities of the ambulatory care sector, especially during certain afternoon, weekend, evening times, and so on. And clearly coming to the first question, there is, maybe I simplified it a bit, because you could also challenge me and say maybe the decrease in the burden of disease is also the result of the health system. It's not only that the reduced need is there, but we see less burden because the hospital and healthcare in general is treating people more successfully. And the whole area of cardiovascular diseases is probably a good point in time. When we look at acute myocardial infarction, we see really visibly decreasing population-based mortality from AMI. And then we ask ourselves, is this due to the fact that as many people as in previous decades develop an AMI, but then are saved by the health system because we have angiography, we treat them very differently. When I studied medicine in the 1980s, I mean, you would put people to bed for 14 days with an AMI, and that changed completely. Or the second explanation is we are as bad as before, but the population prevention programs like in Finland with Eastern Karelia and so on, they worked, and people eat different things, are more physically active. There are studies on this, especially on ischemic heart disease, and the answer it's both. We have 50% fewer myocardial infarctions because people are healthier, food-wise, physical activity-wise, but those people who develop an acute myocardial infarction also experience an improvement in the care quality. So clearly we need to take this into account. But for cardiology, it means we really see fewer people when we look at it into an age-adjusted population. We see decreasing numbers. Clearly, if more people, if the country is growing, or if we have more people in higher ages, which are then more likely to develop AMIs, the absolute numbers could stay similar. But in most countries, they are not really going up, even in absolute numbers, because the relative speaking, they are going down. And we need to make sure that the improved treatment is really available. I mean, and AMI is a very good example, because up to the 1980s, in some countries even later, we would simply put patients into bed. And so the bed could be in a small hospital, and each hospital was suitable for treating AMI patients. Now that we know that coronary angiography, PCI is so important, we need to have the equipment, we need to have the staff which is experienced in this. Stroke the same. When I was an ambulance driver in the early 1980s, we had difficulties in getting rid of the stroke patients, because all hospital doctors would say, I can do nothing for these patients. Now we know it's an emergency, stroke units, and so on. So the same thing there we can do. So we see a decreasing trend in admitted patients, but those who are admitted need more intensive treatment, and we need to be aware for our planning of both, and especially the patients who are admitted, and these were several of my examples, we need to include the quality into the payment system.
Thank you, Reinhard. This is a great bridge to the next cluster of questions, which are about payment models. And here we have three, I would say, and I would just briefly summarize. One is your opinion about the role of the DRG payment system, given the increased attention paid to models such as the accountable care organizations and focus on capitation and bundle payments. And on the other hand, if we're focusing on integrated care, if you have any thoughts on block contracts that would facilitate that sort of progress.
Yes, I mean, the DRG is, besides all the good and bad things which I've already said, said, clearly have the disadvantage that in most countries they are only used for episodes of care. And so these are episodes of care in a longer history of a patient. So we pay the hospital, which only treats the patient for 7 days, let's say on average, and the payment is independent of what happens before and independent of what happens afterwards. And so the idea now is that we not only improve the quality markers during these 7 days, but that partly we can extend the quality markers into the post episode period. For example, that people who get a hip implant, that we want to adjust the hip implant payment by the result, and the result for the patient would mean that he can go back to work, has no pain in the hip and so on. But we need to send surveys or examine the patient, let's say 3 months after the hospital stay, and then retrospectively adjust the payment of the hospital, or say hospital you only get 80% up front, and only if the result is positive you get the other 20%. So this would still stay with the episode-based payment. And then we have the idea that we bundle payment for longer periods of time, whether you then call it accountable care organizations or integrated care models or whatever. The idea is that you have an intermediary between the purchaser and the individual provider, which could be a group of providers consisting of both ambulatory care and inpatient providers. They would go to the purchaser and say, I take care of your patients and you give me the money, which is enough to take care for the whole year. And the idea is that then you have incentives for this network or this ACO or whatever you call it, that they only provide the necessary services, but they do provide the necessary services and skip the inappropriate services for, let's say, well-defined groups of patients with the chronic diseases, where we know we have a risk that they are overtreated in hospitals. This is a very good way forward. For people who develop rare diseases or very high cost diseases, this is not working. For example, I mean, the motorcycle driver who is perfectly healthy in January and who crashes into a tree in April and who needs tens of thousands of euro for the treatment, falls between all these options. So yes, we need to look at more longitudinal annual bundled payment ideas, but we still need to think how we compensate hospitals for really resource intensive shorter episodes of care.
And on the other end of the spectrum of this is the passive purchasing, right? So this was on one of the previous slides, and we have a couple of participants who would be interested in knowing if there are countries that are actually still using this sort of model, passive purchasing.
Well, it's still the norm in many countries that the purchasers, that you have a price list basically, so you define what you would be paying. Could be DRG, could be fee for service. So there's a price list, but you leave quantities open basically, because you don't define and you don't put into the contract under which conditions the service or the DRG gets reimbursed. So this is still the norm in many countries. So we are saying there should be more active purchasing, and not active in the sense that you define a price list, but more really active that you say, okay, hospital, this and this is part of treating my stroke patient well. You need to put him or her into a stroke unit. And if you don't do it, we will, in the extreme case, we will not pay you anything, because this is against our contract. And most countries are not so daring and not so harsh on their hospitals. And currently, clearly in the COVID crisis, hospitals had in many countries a good image because they could pretend that they were the backbone of the COVID answer, something which we will be questioning on Monday, whether that is really the case. But politicians find it hard to be harsh on their hospitals, even though we know they have good reason. We spend 3.7% of the gross domestic product on hospitals, so we should be tougher in really demanding from purchasers active purchasing and to really enforce that vis-a-vis the hospitals.
Okay, thank you very much. I think we have maybe 1 minute for one last bundle of questions, which is more about how the participants can get an overview of different services provided in different countries, perhaps related evidence and prices. And I'm only personally aware of older overviews. So I don't know if you have newer sources.
Yeah, I think, I mean, the Euro DRG project, which was the result of which can still be accessed. So there's a web page, Euro, if you Google Euro DRG project, then you will be referred to this web page. And then what we did, I only showed a few examples here. We looked at a larger number of so-called episodes, so hip implant patients, acute myocardial infarction patients, breast cancer patients. I'm not aware that anybody has really updated these things since then, which would be really a good idea to do this once in a while, because on general, you cannot learn too many things about DRGs. The devil is really in the details, especially if you see the combination between the classification and the payment incentives for particular technologies and for particular treating modalities.
Okay. I think it's probably about time we wrap up. We have a number of additional questions, some of which I think belong in different sessions. So we will be tackling the areas more in detail, like workforce and the COVID specific questions later during the school. So I would not want to go over time now with handing them, if that's okay for you, Reinhard, that we
Yes.
wrap up here. Would you like to add something at the end, or just wish everyone a happy end of the day?
Yeah, I mean, it's only as you rightly say, it's only the second lecture, and we have more particular ones. Like tomorrow, we have on the European reference networks, we have the skill mix on Thursday, and then we come back to all the COVID specific ones next week. So I encourage people to come back to us over the next days, and then also see that where there are more details on the particular topics available.
Okay, well then, thank you very, very much, Reinhard, for the great lecture. Thank you very much, everyone, for listening, for participating, and for staying until the very end of the Q&A. I think we can all enjoy the rest of the evening and see you all tomorrow at 4 o'clock.